Hi folks, I'm Dr. Tom Meade and welcome to another episode of our show. We have a special edition today on hip surgery. I have an expert panel assembled today to answer a lot of questions about hip surgery. Let me tell you a little bit about hip replacement surgery. It is probably one of the most successful procedures in all of surgery, not only orthopedics. It decreases your pain, improves your function, improves your quality of life. But it has been around for over 100 years. The first hip replacement was done in the late 1800s, where they actually took ivory. They took a piece of ivory and they replaced the hip with it, and it was moderately successful. The first metal hip was done in this country by a surgeon by the name of Austin Moore, and that was in the late 30s. But I'll tell you how slowly technology evolved is I'll bet you that most of the panelists have put in Austin Moore prostheses, except maybe Kevin. Have you? So he's taken them out. But you know what? They did pretty darn well. In our training, we put them in. They put some porous-coated beads on them, and it was the standard of care for many years for hip fractures. It improved the life of many a person. Then Sir John Charnley probably revolutionized hip surgery in the 50s, and he came out with a small metallic head. And believe it or not, this is how technology becomes advanced in orthopedic surgery. It was his salesperson that said, you know what, maybe you need a better bearing. Look at these washers that we use in industry. And he said, here's a pretty good plastic bearing. Why can't you put it in the hip? And indeed, that began the plastic or high molecular weight polyethylene bearing. And the Sir John Charnley's hip was successful for over 20 years. It was the standard of care, the gold standard for many years that we've learned how to do hip surgery based on his technique. But there's been a quantum leap in hip surgery over the past several years. And with technology comes information and misinformation. There's a lot of misinformation out, and it's expected that total hip replacements will double or triple in the next 10 to 20 years. The problem is they didn't anticipate that you need surgeons to put hips in. And so there's actually a shortage of hip replacement surgeons. They're not filling the residencies, they're not filling the fellowships. So by default, there's a lot of general orthopedic surgeons out there that by necessity have to put hips in. The average hip surgeon in this country does less than 50 per year. And they're busy guys. They have a lot to do. Perhaps it's not as easy for them to keep up on a lot of the advances. The team that I have assembled here, what I call hip headquarters, right in front of you, perhaps does close to 4,000 joint replacements a year. So if these guys don't know the answers to your questions, nobody will. So that's an impressive number in front of you when the average surgeon does 50 and the guys in front of you do close to 4,000. They've trained at some of the most prestigious institutes in the world. And just to name a few, Harvard, University of Pennsylvania, Syracuse, Penn State, Thomas Jefferson University, the Rothman Institute, Buffalo, Hospital for Joint Disease. So these guys have trained at some of the best places in the country. Individually, let me just quickly introduce the panel. Dr. Pete Sharkey, Professor of Orthopedic Surgery at the Rothman Institute. Pete's an officer in the American Association of Hip and Knee Surgeons. You don't go to a meeting nationally or pick up a journal and find an article that Pete or his residents have written. Pete, along with many of the panelists, are engaged by our industry to design new implants, new hip in the industry. So Pete, welcome. Thanks for coming. Leo Scarpino, perhaps the most experienced surgeon on our panel today. Leo does a ton of joint replacements, and the cool thing about Leo, besides doing thousands of joint replacements, he keeps up on technology. He's actually a pioneer locally in exploring new, safer, perhaps controversial approaches to the hip that decrease some side effects, increase others. So Leo, thanks for coming. Mike Bush and I go back to our trauma days at Lehigh Valley, where Perhaps we did a lot of hip surgery that started out as a trauma and ended up as knee replacement surgery. Mike, too, has done thousands and thousands of joint replacements and trained at Hospital for Joint Disease in New York. Kevin Ambari, stellar surgeon, trained at Harvard, University of Pennsylvania, Charlie Ng's fellowship, and actually has an MBA from Wharton. So with the economic crisis going on, there's a lot of healthcare economic issues, and we could defer to Kevin. So with that introduction, there are many, many issues that are controversial in the world of hip surgeries. People come in and ask, am I too young? Am I too old? Can I run? Can I do this? I've heard that it's dangerous. They're being recalled. This isn't a car that has brakes or a muffler that's being recalled. There's parts being recalled. We can't open the hood of the car. We have to open up your joint. And what's going on with this? What's the truth? You know, I have a metal hip in there. Is there something wrong with it? I heard some of these squeak. Can I have normal sports activity? Can I run? What's my sexual activity after hip surgery? Can you just resurface? What's the alternatives? Where is your hip? How many people come in and say, my hip hurts? And we say, well, geez, that's not your hip. That's not where your hip is. Part of it is you don't even know where your hip is. And it can be misdiagnosed for sciatica, back pain. Do we put cement or grout in there? Can you scope it like you do the knee? What's going on with these recalls? Can you inject it? What's this minimally invasive surgery? I want little scars, but a great operation. So anyway, there is a ton of questions that need to be answered. There's a lot of misinformation out there, and I've assembled, again, hip headquarters here to answer these questions. So that's way too much talking for me. So I want to open it up for the audience, and right after this, we'll take our first question and go right down the line on any burning issues for the panel. Stick with us. Folks, welcome back, and we have our first question from the audience in the back. John. Great question, and I'll repeat it. John's mother-in-law is 87 years old. Is she too old to have a hip replacement, Dr. Scarpino?
Well, from an age standpoint, the biggest factor is her health. The age itself is not a contraindication to doing a hip replacement. I've done recently some 91 and 92-year-old patients who had hip replacements. They did very well. Their family had longevity. They came in and said, my mother lived until 105 for one, 102 for the other. They were healthy. I called their family doctor. They said they're in good shape. Go right ahead and do it. Now, I've got a lot of 90-year-olds who are 50, and I've got a lot of 50-year-olds who are 90. Okay, so there are a lot of 50-year-olds that I wouldn't do because of their medical problems. A lot of times they may have cardiac issues, they've had strokes, they're on Coumadin, they've had heart valves, and that would be probably a contraindication. But at 87, not an issue.
You know, Leo, I'll tell you too, I think a very simple way to think about it is the pain and disability associated with hip arthritis is absolutely terrible. It's considered one of the most painful, disabling conditions you can have. It's almost as bad as breaking your hip. And if, God forbid, your mom fell and broke her hip tonight, tomorrow morning, we'd do a total hip for her. And so, in a sense, she has a broken hip. And it is what it is. She's 87, but she's in good health. I wouldn't treat her any differently. I'd treat her as, just as if she was 67, because who knows? God only knows how long anyone's going to live, and why let her live in terrible pain and suffer?
Yes. Well, that is a great question, and perhaps that is the reason that we have standing room only here in this room, because it's one of the biggest controversial topics in the history of hip replacement surgery. We think of metal on metal as a new procedure, but the metal-on-metal hip replacement, and I'll ask the panel, that goes back 50 or 60 years. I think the McKee-Farrar prosthesis was out there, and it's interesting. It did actually very well. There were good results with that prosthesis, and until John Charnley's hip with his new plastic washer came out, I don't know that there was any data on the metal toxicity back there. But I put a slide up in back of me. This is the number of companies that produce metal-on-metal hip replacement. So this isn't a one company came out with a untested prosthesis. There is a lot of companies out there that are watching this, and that's a great question. You have a metal-on-metal hip. You have no pain. There's some issues with toxicity. It affects your blood. A lot of questions, and let's start with Kevin Ombari to tackle the first question of a metal-on-metal hip in somebody that has no symptoms. Kevin.
I would say that the attention has been paid so much to this recently because of a recall of a particular implant. And the good news is that implant was put into a small number of people to begin with, and the other large majority of people who have metal-on-metal implants are actually doing just fine, just like you are. However, I could understand from a patient standpoint hearing about all this and being somewhat concerned. The best thing, I think, is to talk to your surgeon. Hopefully your surgeon is somebody who does a lot of hip replacements and has kept up on the more modern ways of diagnosing this problem. There are certain things that we have learned over the last few years. Some of it is measuring the metal ions, but that itself doesn't really tell us that much. Some of it is imaging the hip in certain ways to see if there's any damage to the muscles, like you said. You actually said it very well. How you described it was actually a very good description of how we would describe it. Certain things about an MRI, for example, can tell you if there's fluid collection in the hip that may indicate a metal-on-metal reaction. And in certain cases, if you're having trouble, the surgeon may say, look, let's take the metal liner out and put a plastic liner just to put your mind at ease. But some may say, if you're doing fine, we'll just follow this every 12 months, see how you're doing, look at your x-rays, look at your blood levels, and just follow you along. There are tens of thousands of people with very well-functioning metal-on-metal hips who I would recommend not to have anything done because they're doing just fine. And to expose them to another surgery when they're doing well doesn't make a lot of sense. So I would just have a discussion with your surgeon about it. And if that makes you feel comfortable, then that's what I would do.
You really, at this point, just need close follow-up because, just as Kevin said, there's a lot we don't know about this problem right now. For example, you would think that if you had very, very high levels of metal ions, you're more likely to have trouble. Well, it turns out that's not true. There's some people with very, very high levels that are having no trouble, and some people with very low level of metal ions that are having a lot of problems. And so there's a lot of things we just don't know. And so the American Academy of Orthopedic Surgeons is now recommending, if you've had a metal-on-metal hip, get close follow-up every year until we understand it better and get a handle on what the problem is, because we just don't know what it is right now. So you just got to see your doctor. We'll get the answers. They're going to come, but it's going to take more investigation and time. But if you're asymptomatic, the vast majority, just as Kevin said, the vast majority of those patients are going to be fine. You'll probably have that hip 30 years from now.
Question right here in a second, but a show of hands, how many people in the audience have a hip replacement? Wow, we're looking at maybe 50%.
I'm moving to Allentown.
How many have a metal-on-metal hip? Maybe 10%. And of the list behind me of all the companies that produce metal-on-metal hips, I'll ask the panel, Kevin, is it all these companies that have the same issues, or is it more one company where we're focused on?
I think the issue with metal-on-metal in general is some of it is implant specific because some implants seem to have done a lot better than others, and some of it is actually specific to how you position the implants. We've learned a lot more about how certain ways that you position the cup, for example, lead to more wear on a particular part of the metal-on-metal articulation. So I think the concept itself is a valuable concept. The reason we came up with metal-on-metal in the first place is because back in the day, plastic, which was the Charnley surface, used to wear out a little bit too quickly. So when we started to do them in younger patients, the idea is, well, we can take the metal out of the equation altogether and put a metal-on-metal surface. So there was a lot of common sense behind it, and I think that still is a reasonable thought. However, we've learned a lot more. Now that we put them in so many people, we learned a lot more about certain things that make them more likely to wear out more quickly and give people problems, and certain ways to make them less likely to give people problems. So some of it is implant specific, and some of it is actually just some lessons that we learned about positioning of components.
So the young lady in the front and the handsome gentleman in the back, but let's take your question first. Orthobiologics, a great question. Are there other options other than mechanical replacement? We'll answer that right after this break. Folks, we're back here, and we have a question from a patient in the audience who had a metal-on-metal hip, and unfortunately, she had that revised. Her symptoms have resolved for the most part, but she asked an interesting question. In other parts of the body, specifically the knee, the ankle, the talus, we do have more biologic approaches. These joints are a little more accessible, but I'll ask the panel, Mike, are you aware of any orthobiological approaches short of putting metal and plastic in the knee?
As far as the hip is concerned, I don't know of any biologic implants that we do in the hip. It's certainly been tried in the knee. It's been done in the ankle. There are some other techniques we can do in the knee and the ankle where we cause small fractures in the bone and try and get new cartilage to form. But I'm not aware of anything in the hip. And you have to go back to the gold standard of what we know works. Is a well-done hip replacement is going to give you excellent relief of your pain, and good function and mobility. So you got to be careful about some of these new experimental type of things. That's why we've gotten into all these problems. We thought when we did metal on metal, that was going to end a lot of problems that we were having with hips. And we just found out it created a new set of problems.
One thing I do want to add in general about the whole articulating surface of the hip is that because of some of these issues, the vast majority of hips being done in this country right now are a metal ball and a plastic socket, which is sort of the original and best. It's the cornflakes. And the reason is surgeons don't want their patients to even have a small chance of having any of these problems. So despite a lot of the attention being paid to this in the media, this is more of a problem in the past than for the future, because I think most of us now don't want to have that controversy be even a part of our patients' lives at all. So I would not lose sleep over that going forward, is basically what I would say about that.
One of the problems with orthobiologics is it's probably the area of greatest research in orthopedics over the next 10 years. The problem is you have to get it early. We are not as good as replacing biologic structures. I call it cartilage spackle. We would love to go in and find cartilage spackle and get it to grow in there, but we're actually good at it in small lesions in the knee. We can actually grow cartilage in the laboratory and put it in, but we can't get it to stick real well, and that's a joint that's very, very accessible. Most folks that come in that need a hip replacement, you're well beyond just replacing the surface. The bone has deformed underneath. The biology is not amenable to growing new cartilage in there, so that's the issue. It takes a little more vigilance, a little more imaging early on when you have silent disease, and that's going to be the big question. There's actually a new technique that both Peter and I are involved with in the knee that is very, very early joint preservation when we see bone marrow edema, and that's before the joint collapses. And we're working on some research projects to inject calcium phosphate in these bone marrow edema lesions to support the cartilage in the knee joint. It's been used in the talus, and I've had some people use it in the hip. It's very early, it's experimental, it's not out there for general use, but there is a lot of research going on in that regard.
Yeah, if I can make a comment on the cartilage spackle, it's what everybody wants. Nobody wants to get their joint replaced, but you got to understand, once you lose that cartilage, how hostile that joint environment is. For example, when you walk, you put about 8 to 12 times your body weight on your hip joint. So if you weigh 200 pounds, you could be putting over, what would that be? That would be over a ton of pressure on the hip joint. So you can imagine taking a little bit of paste and trying to put it on that hard bone and then putting a ton of pressure on there, you're just going to destroy those cells. It'd be like, trying to grow grass on the moon. It'd be impossible. So we just don't have that technology at this point. And so what we're doing is we're looking at, instead of treating the surface itself, going below the surface and trying to treat the disease from below the surface and get new cartilage to grow up from down below. And we are having some success with that. And as Tom mentioned, we're doing some research on that now. We've done, I think it's over 150 knee patients who've had the procedure. Tom's done a lot of them. And we've had some good results with it.
So it's a work in progress. Yes. So that's a good question. I'll repeat that. The gentleman's wife had a metal-on-metal hip that was symptomatic. It was revised with a cup with screws in, and the foundation of the hip was soft and weak and osteoporotic, and it didn't take the screws well. So the question is there both systemic and local issues that would preclude a good revision, and what other preparation can the surgeon do to prevent even a third revision in that case? Mike, I'll bounce that off to you.
Well, this is a complicated problem. And at the time of the second surgery, you really have to make sure that you're anchoring the cup into good bone. And if you don't feel that you have good bone there, you have to take certain steps to get to the good bone, whether it's using a bigger cup, putting some bone graft in there. There's a lot of technical things that you can do, but usually there's enough good bone around the removed prosthesis that you can anchor in a cup.
It's the soft tissues and the bone, and unfortunately, I think both people here today who have had problems are women, and women are having a lot more problems with this than men, and we just don't know why.
I've done 2 ASR revisions in my patients. When I went in, I was prepared to evaluate the bone. And we know that there's going to be soft tissue involvement, and there may be bony involvement as well. So we're prepared for that, and we're aware of that.
Any other metal-on-metal concerns? Yes.
What is the composition of the metal that you're inserting? Or is the chromium and cobalt coming from bone? Where is it coming from? Where is it leaching?
That's coming from the prosthesis.
What is the composition then
Good.
of the...
Chromium, cobalt, a little bit of nickel, molybdenum.
That's it?
Yep.
So you're losing part of the prosthesis when you're leaching out the chromium and the cobalt.
That is correct.
You're not really losing the prosthesis. We're talking about microscopic amounts. They measure it in billionths of particles. So that prosthesis is as strong as it ever was, but it's the effect of these micro particles and the body reacting to them.
However, they play havoc on the individual's health, don't they? An elevated chromium, an elevated cobalt?
Yes, they can. But what I'm saying is that the prosthesis itself is not weakened, and if you were to look at it, you wouldn't see anything different about the actual prosthesis.
And when you hear this stuff, you probably think, we must be out of our minds to do these things. But to do a metal-on-metal hip. But in medicine, there's a trade-off between everything, and Kevin mentioned it earlier. The reason we started doing metal-on-metal is because for the plastic hips were wearing out quicker than we wanted them to wear out in young patients. And so now all of a sudden you got a 45-year-old person who needs a total hip, and you go in there, you put the plastic one in, it wears out in 15 years, and you're redoing it. We believed that we could put a metal hip in that person, and it would last them the rest of their life. Well, then we started doing it. At first it was working. We said, gee, it's working so good for this 45-year-old. Let's do it for this 62-year-old woman. Because once a woman reaches age 50, she has a 1 in 3 chance of making 100.
Peter, these are great topics. Let's do a second show on this. I can't believe the time went so quick. Thanks. I want to thank the panel for coming here, answering the questions. What a controversial topic. We're going to have another show, folks. Stick with us. You're not going to want to miss our next show. Thanks for joining us. We appreciate your time.